Welcome. We are so excited to have you with us today. This is the presentation on essential elements for teaching addiction counseling courses. And I want to let you know that this is being recorded. The entire presentation is being recorded and it will be disseminated to you in 7 to 10 business days. So folks who are not able to join, they will also be sent this via email. And that'll be in about 7 to 10 business days, and you'll get that via email. It will also be posted on the Springer Publishing e-catalog page for the book that these 3 authors are responsible for, and we'll be talking about that in a little bit. So again, this is being recorded. It will be disseminated out to everyone who's participating and everyone who registered in about 7 to 10 business days. We are going to be taking questions. So if you have a question for our presenters, please post your question in the Q&A box, and we will do Q&A at the conclusion of today's presentation. So without further ado, I'm going to go ahead and introduce our presenters right now for essential elements for teaching addiction counseling courses. First, we have Dr. Alan Cavaiola, who is a professor and director of addiction studies in the Department of Professional Counseling at Monmouth University. He has been teaching substance use disorder related courses for the past 25 years. Then we have Dr. Amanda Giordano, who is an associate professor of counseling at the University of Georgia. She specializes in addiction counseling and is the author of another book that we publish, A Clinical Guide to Treating Behavioral Addictions. Finally, we have Ned Golubovich, who is an assistant professor in the Counseling, Marital, and Family Department at the University of San Diego. Dr. Golubovich is scholarly focus is on areas of addiction and trauma. He currently serves as a program director for a federally funded opioid workforce expansion program. And with that, I'm going to go ahead and turn it on over to today's speakers.
Hi, and welcome everyone. Thank you so much for being here. We're really excited to speak with you today about our collective experience teaching addictions counseling courses. I asked my co-presenters right before we jumped on how many years they've been teaching. So collectively, we have 43 years of experience teaching addictions counseling courses. And our hope today is just to share some of our experience and insight with you. We hope that for those of you who are teaching an addictions course or plan to teach one, will find this information useful as we talk about some of the essential elements for our courses. So you can see that we have an ambitious agenda. So in the next 45 minutes or so, we plan to cover a couple of things. We want to talk about the importance of student buy-in for an addictions class. We're going to talk about the importance of empathy and diversity. We will discuss some individual and family counseling approaches that we integrate into our classes, the importance of training in group counseling. Also, we'll discuss some assessments that we use in class and the importance of understanding substance use disorder diagnoses, recognizing co-occurring disorders, and then we'll also touch on evidence-based techniques that we teach our students and the importance of case examples and some notes from the field. So we're going to do all of that in the next about 45 minutes. And then, as Rhonda said, if you have any questions along the way, please send those in and we'll spend time at the end answering your questions. Okay, so first I just want to talk about the importance of getting student buy-in for an addictions counseling course. If your class is an elective, or even if it's a mandatory course, not all of your students are going to understand why it's relevant to them. So I have found that in teaching this course over the last decade, I get a lot of students saying, you know, I'm here and I have to be here, but I don't really think this class is relevant to me. And so I now spend the first full class talking about why it is relevant for counselors in all settings. I found that after this lecture, I really get a lot more student interest and participation in the topic because they now see how it's relevant to them. So just a couple of tips and things that I do when I'm talking about my students who plan to work in community settings. A few of them want to work specifically in addictions treatment. A lot of them want to work in private practice or agency work that's not directly related to addictions. So I simply share the prevalence of both chemical and behavioral addictions in the US. And those numbers alone are very striking. They are hard to ignore, and they usually land with students in such a way that they say, wow, it does look inevitable that I will work with someone whose life has been touched by addiction. I also explain how individuals with addiction may present to counseling with other issues before they end up in addictions treatment. So they may present with marital issues or depression or suicidal ideation when the cause of some of those presenting concerns is addiction. And that's why it's important for counselors to be able to recognize and respond to addiction, because that might not be the first stop in the client's trajectory of getting services and clinical help. Now, at my program, we have a school counseling track, and I love teaching addictions courses to my school counseling students. Almost all behavioral addictions start in adolescence. And so we see that first use of cannabis, the first use of alcohol, the first experience with pornography or gaming or gambling happening in adolescence. So I tell my school counseling students that if they can recognize addiction and intervene early, that could change the whole trajectory of that student's life so they don't end up in treatment with me in their 40s or 50s because their lives have spiraled out of control. So the importance of early intervention. For my students who want to work with elementary school kids, perhaps they're play therapists, they also are like, how is this class relevant to me? And I tell them that it is so important for them to understand how living in a home with active addiction can impact a child's development. And that if you're working with a child who's living in a home with active addiction, we can have an incomplete or an inaccurate conceptualization of that child if we don't understand how addiction in the family could be an adverse childhood experience, could be leading to trauma. We also talk about the role of substance use in experiences of child abuse and neglect. For college counselors, as you can imagine, that's a pretty easy sell. We talk a lot about just the prevalence of chemical and behavioral addictions among college students. So if you think about binge drinking, cyber sex addiction, gambling, prescription medication misuse, cannabis use, all of these things, we have a lot of data to show how prevalent it is in the college setting. So college counselors or students who plan to be college counselors usually buy in pretty quickly. And then for my students who plan on being couple and family counselors, we talk a lot about the impact of addiction on relationships. So if one partner has a chemical addiction, how that impacts the other partner. And then also if one partner has a behavioral addiction like sex or pornography addiction or shopping addiction or gambling addiction, how that impacts the relationship as well. And we talk about things like Al-Anon and Gam-Anon and things like that. So I think it's very important, and we try to say in the very first chapter of our textbook as well, that all counselors in any setting must be able to recognize and respond to addiction. I play a little game with my students where I have them tell me the setting they plan on working in, and then we cover information about why knowing about addiction is relevant for them. And so by the end of that class, we get a lot of buy-in, which really changes the tone of the course.
And Amanda, if you don't mind me just adding there a bit, what I really tried to drive in my students during this first class is not a matter of whether they're going to see people who struggle with addiction, but rather two other important questions: when they're going to see, and then most importantly, if they're going to recognize that is taking place and impacting the person's life. So really trying to shift their mind frame from, oh, well, I might not, or I might choose not to, but rather you are, you will, and it's a matter of you recognizing and being able to do something about it to help your client.
Excellent. Thanks, Ned. All right. And so I also strongly believe that one of the main purposes of an addictions counseling course is to develop empathy. We know that a lot of students come into these courses with preconceived notions about addiction. They may be adhering to the moral model of addiction. They maybe have someone in their life who is either in active addiction or in recovery that has really colored their perception of future clients with addiction. So knowing all of that, I explain right away that this course is designed with empathy in mind. So all of my activities, all of the components of my course are really designed to increase students' empathy for addicted populations. And that's for those with chemical addictions and with behavioral addictions. And so I do have some students who seem to have empathy and an understanding of what it's like to have an addiction to a drug of abuse. But when you ask them, like, what's the first thing that comes to your mind when you hear sex addiction or gambling addiction or exercise addiction? Sometimes we see those biases coming back in and that adherence to the moral model again. So really trying to make it your goal as a counselor educator to increase your students' empathy, because research tells us that it is empathy that is one of the stronger predictors for positive outcomes in addictions treatment. So I like to use this quote in class. You're welcome to use this as well. It's from Carl Rogers. He said, "The highest expression of empathy is accepting and non-judgmental. This is true because it's impossible to be accurately perceptive of another's inner world if you have formed an evaluative opinion of that person." So this quote gets us into conversations about stigma and stereotypes and biases about people with addiction. And I think that's an important starting place. And I let them know that as they go through my class, my hope is they're going to start to unravel some of those messages that they've learned that has led to this internalized bias around individuals with addiction. One of the things that I have found to be most successful in getting students out of that moral model is to provide neuroscience about addiction. I think anyone teaching addiction classes needs to be familiar with the neuroscience of addiction. As my students learn how drugs of abuse and rewarding behaviors impact the brain and lead to these neuroadaptations, you can see their empathy growing for this population, that it's not just a choice. It's not something that you say, why don't you just stop? They're seeing how the brain is changing, and they're seeing how some individuals are predisposed for addiction in ways that are different than others. And so teaching neuroscience, I think, is a huge part of the course. And then, like others who teach this class, I have my students attend 12-step or other peer support group meetings. So they have to attend 3. I have them go to 1 AA, 1 Al-Anon, and then one of their choosing. And that one of their choosing could be a non-12-step like Smart Recovery, or it can be a group for a behavioral addiction. The absence project is something that I do in class, and I do the absence project for the full 15 weeks, which I know not everyone does. I've heard from some other faculty that they do it for 4 weeks, and I do it for the full 15. And part of it is for that empathy development, that my students find it very difficult to abstain from something desirable for 15 weeks. And so that's how I present it. I say, we're not trying to emulate recovery from a drug of abuse or a behavioral addiction. Instead, I just want you to experience what it's like to go without something desirable for 15 weeks. And by the end, they tell me that, oh, the book was great and lectures were great, but I learned the most from my absence project and how difficult it actually is to go 15 weeks. And of course, we have the conversation, you only went 15 weeks, but our clients have no end date. They are abstaining 1 day at a time for as long as they can, hopefully for the rest of their lives. And so another empathy builder. I have them read autobiographies. I like for my students to hear from people with addiction. So we use the book Broken by William Cope Moyer. I love that book. I think it's a really great read for students because he talks about his thought process as he's going through active addiction. Of course, he wrote the book when he was in recovery, but he remembers what he was telling himself, what he thought about his first counseling sessions. It's a great read that my students learn a lot from. And then also documentaries and TED Talks. So I think, again, hearing from people who are in recovery themselves is a great way to develop empathy.
Amanda, one of the TED Talks that I use quite a bit, if any of you are familiar with Johann Hari, He does a TED Talk. It's called Everything You Know About Addictions is Wrong. He kind of cites some of the research that was done by Bruce Alexander pertaining to Rat Park, and really challenges a lot of thought regarding, almost like the etiology of addictions, and also gets into the importance of environment, because I know we have a lot of emphasis on neuroscience, and I think neuroscience is especially important, maybe in understanding, for example, post-acute withdrawal. So you have acute withdrawal, but then you have those maybe 6 to 12 months where people could still be experiencing things like irritability and other problems. So so again, it's good to be able to kind of present other viewpoints regarding the etiology of substance use disorders.
Excellent. Thanks, Alan. I don't think we cover it in this presentation, but I rely heavily on the biopsychosocial model of addiction, which is really helpful to bring in all those dimensions, and students become aware of how complex this disorder actually is. The last piece that I think is important to say up front, so these are all things that I kind of start my class with and then weave throughout the entire course, is a focus on diversity. So one of the things that I think is very important for students to know is the history of drug laws. And when you look at when drug laws came to be and why they came to be, you see that it has a lot more to do with who is using the substance than the addictive nature of the substance itself. So you start to see how systemic oppression, racism, and discrimination played a role in the history of drug laws and drug exposure, especially when you think of Native populations. So it's really important to give that context. I can get on a soapbox here, I won't, but one of the things that frustrates me is when presenters or professors will just put up statistics about how much substance is being used by members of different racial or ethnic categories. And you'll say, see, there are some groups that tend to use more drugs, more alcohol, tend to engage in pornography use more, and they just present these statistics without any kind of context. I think that's really doing our students a disservice by not equipping them with the information that they need to have a cultural humility as they approach addictions work. If you look at both the history of drug laws and the war on drugs, you'll see a lot of systemic oppression in those movements. And that's important for us to be aware of as addictions counselors and as counselor educators. We also know that marginalized group members face a variety of risk factors that members of privileged groups might not experience. So risk factors for substance use, like the experience of oppression and recognizing that things are unjust and being faced with injustice, discrimination, and race-based traumatic stress. Some individuals can choose to cope through addictive substances or behaviors. We know that generational trauma is linked to substance abuse, as well as acculturation stress and minority stress. So I think if we don't know those things, if we're not paying attention to them in class, then our students can walk away thinking, oh, some members of marginalized groups use more substances than others, without getting any kind of context of what are those risk factors and what predisposes some cultural groups to maybe be more at risk for coping through substance use. I also think it's important to talk about targeting practices. And this is where our students can really step into their advocacy role when they're aware that tobacco companies, alcohol companies, the lottery scratch-offs, gambling, they can target certain communities, and they tend to be less affluent communities that you see more tobacco ads and alcohol ads, more access to lotteries, scratch off, and gambling. So that's something that I think is important to weave in throughout your class. So more than just telling your students that racial disparities in addiction statistics exist, we need to explain why those disparities exist by giving some of this context. And then as we teach our techniques throughout the class, we don't use that one size fits all technique. If you look in the literature, there have been some great individual, family, and group addiction interventions that have been tailored for different cultural groups. So we talk about these culturally adapted interventions and strategies, the importance of broaching culture with our clients who are there for substance use disorders, and how we can partner with community leaders as well. A little bit of my research has shown that Native populations often go to tribal leaders or family members first as a way of addressing substance use before they would go to a non-native counselor. So how do we work with communities to strengthen and help community members rather than saying, oh, to get help, you have to do it our way and it has to look like this. So again, great conversation topics to weave into your class.
Okay, so a couple of things that we offer in the book are some different types of individual counseling approaches. The idea is that we really want to be able to provide students with some tools that they can use, things that might be helpful with particular clients. We know that not all approaches work well with everybody, so we really try to, just provide some different types of techniques and approaches that might be useful. So one of those would be like solution-focused counseling. A lot of the solution focus folks felt that there was too much of an emphasis on kind of the disorder itself and consequences of substance use, et cetera. So they kind of shifted gears a little bit in terms of trying to get clients to take a look at what will things look like once the substance use disorder is no longer there. So things like the miracle question, exception finding, et cetera, are particularly useful. So we get into those in the book. REBT is also particularly helpful, especially for clients who might rationalize their use based upon certain like irrational beliefs. Like drinking is the only way to be able to relax or the only way to fall asleep or things like that. So REBT is particularly helpful in terms of being able to challenge some of those irrational beliefs and being able to take a more rational approach towards, substance use, et cetera. Behavioral approaches are helpful. Use of contracts, for example, can be very helpful with clients in terms of goal setting, et cetera. 12-step facilitated counseling is particularly useful as well. And we talk about this, especially with clients who may have been involved in 12-step meetings at one point, but maybe had a negative experience of some sort. But we talk about ways to be able to address that in a way where clients might become more receptive. And then we also incorporate some techniques from existential and Gestalt therapy as well. So we also have an entire chapter on family counseling, because as we know, addictions just don't impact the individual itself, but it impacts their family, their significant others, et cetera. So we take a look at some of the impact issues, in terms of talking about family roles, even roles of children who are growing up in homes with substance use disorders. We also emphasize the idea that there are various treatment points at which you might see families. You might see them when their loved one is actively using. So how do you then work with a family in that instance? Because usually they're going to try to get some ideas as to how can we get our loved one in treatment. So we talk about things like intervention, or we might even talk about the craft approach, for example, things that could be helpful to them at that particular point. The other treatment entry point for families is when their loved one does get involved in treatment. So that would be maybe when they go into a program, IOP or an inpatient program, et cetera, and then how to best work with families at that particular point in time. The next treatment entry point is then when the person, their loved one, is then being discharged from maybe treatment or residential treatment, for example. And here we talk about, the kind of the walking on eggshells phase and some ways to be able to, for families to be supportive without being critical or hypervigilant and that sort of thing. Also, naturally, we try to get families involved in, Al-Anon, Nar-Anon, Gam-Anon, et cetera. We also talk about family assessment. Genograms are probably still the best way to be able to assess families. So we review that in the textbook in terms of how to best do that, how to approach a genogram, et cetera. And then we talk about some other family techniques. Some of those are usually based on various models, whether it be family systems model or structural model, family disease model, et cetera. And then we also talk about specific techniques and approaches that are used with adolescents. because they really present as kind of a special population, and kind of using a multi-systemic approach seems to be the most helpful, because whenever you're working with adolescents, as most of you know, you're not just working with the teenager, you're working with their parents, sometimes their siblings, the school, sometimes the courts, etc. So it's important to kind of use that kind of a multi-systemic approach.
Yeah. And one of the things I like to do in my class for both individual and family counseling is to show clips from movies. My students tend to like that too. And then we conceptualize the character from the movie and then talk about what counseling or treatment would look like. So for family counseling, I really like the film Rachel Getting Married with Anne Hathaway. And she is someone who's in recovery from drug abuse. And then you see her come back for her sister's wedding and how that family interacts. So there are great resources out there too of how to practice some of these with, yes, a written case study, but I find movies are really helpful too.
Yeah. As a matter of fact, speaking of abusive movies or films with families, a recent movie that came out is called 4 Good Days. So if any of you have seen it with Mila Kunis, I believe, and Glenn Close, also a great example of family dynamics and how, again, how substance use disorders, in this particular instance, opioid use disorders, how it impacts on families.
Mm-hmm.
When teaching group counseling or focusing on group counseling class, my 2 overarching goals for that class is to try to communicate a little bit of realities or expectations for the addictions field, so students have a sense of what they're stepping into and what will be awaiting them, and then also to expand a little bit on maybe material they learn in the group counseling class and how particularly addiction issues are addressed via this modality. So I like to start this class by asking a really general question of how many of you want or plan to work and practice group counseling. And to be honest with you, not that many hands go up. I believe when students come into counseling field, they have this peculiar picture of how their career is going to look like. And for most of them, that picture looks like they sit on one side, one client sits on the other side, and the magic takes place between the two, right? So not that many students have in their mind a group of people. So I really use that as a positioning framework to communicate that group counseling, if you choose to work with addiction issues specifically, no matter the setting, outpatient, inpatient, transitional work, it is inevitable for you to be doing groups and facilitating group counseling. And not just because it is most commonly used, it is most effective, it is the most economical way to approach addiction. So being able to use some multicultural factors and issues of access to counseling as an argument, but also group counseling might be mandated, because many clients who enter addiction treatment might be mandated through maybe parole or court issues. They might be mandated to attend particular groups. So really understanding that there is no way around it. It's not a matter of choice again, but rather you're going to be faced with this if you're choosing to work with addiction issues. So this kind of reality of this is going to happen, you probably should be ready for it. And from there on, moving into kind of expansion of what they learned in their group counseling class, because a lot of things that are covered in group counseling class, especially when it comes to client screening and group selection, are aspirational. So we cover all these things, right? You want clients to have a relatively uniform presenting issues, to be able to work together, be in a relatively same place in recovery process. So all these are aspirational things that are really important to keep in mind with selecting a group and forming a group for group counseling that would actually contribute to clients' well-being and then recovery process. However, once they enter the workforce, especially if they work in inpatient settings, that all goes out of the window, because a lot of times structure of the group membership, number of people that have in the group, essentially they have no agency over, right? So those are structures within the setting that I made. And even as far as the things being groups being in an open group or closed group, how clients come in and leave. So that a lot of these things, clinicians do not have any agency over, a decision over. So understanding, yes, these things, you want to pay attention, these therapeutic factors are relevant. However, once you enter the workforce, there are some things that you might have to be flexible on. And quite frankly, some things you have no choice over. So being able to understand how do you then work from a group when you show up and group is present and clients leave as they graduate and clients enter as they enter treatment. So understanding dynamics between closed-ended groups, open-ended groups, and how to best facilitate this piece. Along that discussion, I also like to talk to students about their boundaries and how they set up boundaries between themselves as a facilitator and the group members, and then setting up boundaries among group members. It is really important because sometimes students get lost, and especially if they early on in their career, their practicum or internship, they get a little lost in the groups, and it's difficult for them to maintain boundaries of their role as a facilitator and what that means. And it's also sometimes difficult for them to maintain boundaries when facilitate different kinds of groups. If they're facilitating process therapeutic group versus psychoeducational group, it's difficult for them to navigate from more of a teacher role in psychoeducational group and have more authority, following curriculum, being able to achieve and click off boxes that, quite frankly, maybe county wants you to click off, and then being able to actually be immersive in the process of therapeutic group and being able to more process and deeply engage with the client on some of the interpersonal work that might be needed. So understanding how you as a counselor might have to take, or rather switch hats and behave differently, position you differently, and most often with the same groups of people that you might be seeing in the different varieties. From there on, I like to talk about diversity of groups in group counseling, so types of group, open, closed, as well as the variety of groups that might be facing, as I already mentioned, psychoeducational groups, maybe some, for example, anger management groups, or versus more therapeutic and deprocessing groups as well. And then also looking into how some groups might differ based on a particular setting. And so if they're inpatient group, intensity of their group, membership of their group, how often they meet, might look very, very different if clients are in an outpatient, or maybe clients are transitioning from treatment and finishing their treatment, so having a more kind of a recovery, prolonged recovery type of group. Mm-hmm. And then the last piece that I like to really focus on is this intangibles of group counseling, and really the richness, right? So trying to communicate why this is so important and how impactful it could be for clients. So really trying to speak to, even highlight the importance of peer-to-peer interactions, understanding how much they can hold each other accountable, how much a resource they can be for each other, how helpful they can be to each other, and understanding that you as one individual who is a counselor have limitations in regards to how much you can even provide, and even simply how often you can be there for the clients, and understanding the power of the group, power of the peers, and the role they could have in the recovery process. I also like to look into Yalom's therapeutic factors and cover all the 12 therapeutic factors, but then be very, very intentional to highlight how each of these factors actually implies specifically for addiction counseling, right? These therapeutic factors are written in a far more general sense to be applicable across groups. So being able to really specifically position it to addiction counseling groups and how each one of those factors could actually work and help people in recovery from addiction issues. And the last piece is the theoretical framework, so understanding a number of different theories that could be used to facilitate groups, and understanding developmental stages of the group. So sometimes students panic if the group is entering that storming stage and there's a little bit of conflict, they're being a little challenged. Maybe they ask, well, have you ever used drugs? Have you ever been in recovery? If the answer is no, there's a little panic. Oh my God, they don't think I can do this. So understanding from developmental perspective of, yes, that is natural. Some of these things you can expect to see no matter who you are, no matter which group you're running, right? Some of these things are just natural regarding the development and transition of the group process. So being able to allow students, to relax a little bit, embrace their position as well.
Yeah, and for those of you who enjoy experiential learning processes, I think the group counseling lecture is a great time to do some experiences with your students. So I was trained in an intensive outpatient program where we ran a lot of addictions groups. And so I took some of those group activities and interventions, made them appropriate for a class setting. And then I have my students sit in a circle and we actually go through an activity or two and process what is it like not only to be the group facilitator, but what did it feel like playing that role of a group member? And that can be a really powerful class lecture as well, to actually have them go through some of these group activities.
We also spend time in the book talking about assessment and diagnosis. So naturally, we, go over biopsychosocial assessments. This is also a good opportunity for students to pair off and then to role play doing a biopsychosocial assessment based on maybe a client that they may have worked with, or maybe even a client that they kind of make up or something. We have a lot of case examples in the book, so there's different opportunities to be able to do that. One of the things about biopsychosocial assessment, I mean, a lot of times students approach it as a task of information gathering, which it is, but I mean, we're also trying to look for risk factors, because we know when people come into treatment, they're not there saying, oh, I thought it was a nice day, I thought I'd come in and get help for my addiction, but so therefore, we're oftentimes trying to decode what's going on and how much some of the maybe different problems the person is experiencing, how does it relate back to their use. We also really advocate for the use of assessment measures as part of the biopsychosocial assessment. I just kind of skipped down a little bit here because having some kind of an objective measure really becomes important just in terms of being able to get a different view, or maybe even asking questions that we might not necessarily cover in a biopsychosocial assessment. So we, a lot of times we'll talk about the use of the SASE, because of the advantage that it uses both direct and indirect questions. So we talk about how to score the SASE and how to use it, as well as other measures, the audit, the MAST, et cetera. Part of the assessment also needs to include mental health screening as well. We want to know if people are struggling with other kinds of issues such as depression, anxiety, et cetera. So a lot of times a biopsychosocial assessment will incorporate aspects of mental health screening, just so that this way we're not missing something. Talk about the differences between screening and assessment. Screening, that being, does this client meet the criteria to come into your program, whether it's IOP or outpatient or medication-assisted treatment, whatever it might be, versus assessment, which is more in depth, for example. Then once all this information is gathered, we talk about how to conceptualize everything, how to bring all those different elements together, and then leading into the giving the client some feedback based upon what information you've gathered. Clients want to hear your opinion. They want to hear what you're thinking, et cetera, based on what they've told you. So that's important too. And then that kind of springboards into treatment planning, because ideally a treatment plan is collaborative. What are the client's goals? What do they want to work on? Even with somebody who's mandated to treatment, their goal may be that they want to get the courts off their back, or the if they've had a DUI, they certainly don't want a second or a third one. So you try to join with the client based upon, okay, how can we work on a plan that will help you to avoid future involvement? So in the book, we talk about treatment plans that are kind of in compliance with JCAHO and CARF accreditation, because most of our students, especially when they're accumulating their field hours, hopefully will be working in accredited programs. So we talk about how to write those treatment plans.
And when talking about co-occurring disorders, I think it's really important to start from this kind of historic perspective and acknowledging the lack of recognition of co-occurring disorder that was existent for a very long time. So it's scientifically rejected in some ways, and it's still playing a role to this day. Just a few years ago, when I was in my master's program, I know facing this reality of clients who had co-occurring disorder coming to substance use treatment facility where I was placed, and then being told, oh, no, you need to go address your mental health issue first at this site, and then come back to us to address your addiction issue. And then once they got to that community mental health side, they're being told, oh, no, you really have to address your substance use issues first. That is the problem. And then come to us and we can address that issue. Unfortunately, that way of conceptualizing substance use and mental health issues has not gone away, right? So it's really, really important for students to understand this historic perspective, this dichotomy in treatment that we have seen before, that still currently is playing a role because we still have a lot of practitioners who are present in the field who haven't received any addiction-related treatment. So it's not that maybe they don't want to treat, but they might not feel actually prepared and able to provide treatment for addiction issues. So understanding the gap in the treatment settings still exists, and a lot of addiction issues are being overlooked because people simply don't screen and don't understand the prevalence rates and presentation of co-occurring disorders. I also like to talk a little bit about theoretical perspective, because there's always this kind of mysterious question of, well, how do co-occurring disorders begin? Like, which one is truly that bond disorder that causes the other? So looking into some of these models and theories, they look into, yes, addictions are caused by mental health issues and are seen as a coping mechanism, or maybe people just use it to exacerbate the positive effects, or looking at the other way and models of, oh yeah, actually addiction issues started first and it's triggering mental health issues. So looking into some of these theories and frameworks that provide some explanations, and then really try to understand, to help students move away from that. So move away from those positions and understand that that's it, that co-occurring disorders exist. Person has two disorders or more that are occurring at the same time. And then moving a little bit into more practical consideration regarding co-occurring disorders, and the most important being the assessment and diagnostic consideration, because that's where a lot of misses take place. If the assessment doesn't take place, well, guess what? Then proper treatment is probably not going to take place either. And we use the 4 quadrants model that we review in our book to help as an assessment aid. The students are being able to recognize in which quadrant would a client fall based on the severity of presentation. So starting quadrant 1, or for low severity mental health issues, low severity substance use issue, and all the way to quadrant 4 being the high severity mental health issue, high severity of substance use issue as well, and to look into acuity of both presentations and seeing this nuanced needs of the treatment. And then moving forward with the treatment implication and really reviewing the treatment models that are still present, starting with the sequential model of treatment, when you decide which disorder is more acute and start treating first, to this parallel model that proposes both disorders being treated as simultaneously, however, by different professionals. So looking into some real issues with those models, sequential and parallel, and then presenting the integrated model as a really way to go of integration of care for both disorders, and how truly they cannot be separate because they don't exist in clients' life as separate. Clients don't have the time in which they struggle with substance use and time in which they struggle with mental health disorder, but they are truly intertwined. So understanding that the treatment also has to be integrated to the same level. And then finally in the book, we cover the frequently co-occurring disorders, just to help students understand better, well, if a client presents with this particular disorder, it might be a good thing for me to assess for substance use, looking from the risk factor perspective, as well as some nuanced presentation and how some of the symptomology might be exacerbated, and some treatment implications regarding these most frequently co-occurring disorders as well.
Excellent.
Well, one of the things that used to occur was that if you had a client who had a kind of a relapse pattern, that in the old days we used to always blame the client. They weren't serious about the recovery, they didn't hit bottom, those kinds of things. But now the thinking has shifted a little bit, that perhaps this might be somebody that does have a co-occurring disorder. As a matter of fact, that was the case with I was at a conference a couple of years ago. I heard David Sheff speak. He had written the book Beautiful Boy, was made into a movie. So I actually heard a podcast also with the son. And he said he was in his 3rd rehab, because he put together some plain time. He was going to meetings, he's involved in counseling. And then what would happen is he'd relapse. And, it wasn't until his 3rd rehab, I think, where somebody said to him, the intake counselor said, could you sign a release so we could get your previous evaluations? They were looking for mental health screening, maybe a psychological eval. And he said, I never had a screening. What are you talking about? So they said, okay, well, we're going to have you see our, medical director or psychiatrist. And kind of lo and behold, there was a history of bipolar in the family. And apparently that was the thing that made the difference. because, he was then going to put on medication, and it was helpful. It was a mood stabilizer, so it wasn't going to endanger his recovery. And from there, he's now had, continuous clean time, sober time. So.
Yeah, that's great. And if you want to do a fun quiz with your students, I do this with them, and they don't actually love it because it's a little bit tricky, but it's very real life. I give them a set of symptoms and I say, now I need you to tell me based on this set of symptoms, like a client comes in and he's hearing voices that no one else can hear. What might he be intoxicated on? What might he be withdrawing from? Or what might he be experiencing in terms of mental illness or disorder? And I do that for about 6 or 7 different scenarios. And it gets my students to recognize if someone comes in with they're lethargic and they're depressed, they have flat affect, yes, it could be a mental health concern, or it could be intoxication on a certain class of drugs or withdrawal from a different class of drugs. And so by the end of the semester, they are able to complete my quiz knowing I need to assess for these drugs. Are they intoxicated, or are they withdrawing? Or is it, are these symptoms representative of a mental health disorder? And that's something that we see for those who are teaching CACREP accredited programs. They want our students to understand the etiology of addiction and addictive behaviors, and how symptoms of substance use disorders can mimic mental health concerns, and that students need to be able to assess and differentiate between the two.
And then finally, in the book, we really focused on the evidence-based techniques, and we dedicate a whole chapter to the MI as an evidence-based approach to addiction treatment. However, before I start teaching the MI, I do like to frame this class of what expectations students should have of this class. And I'm very explicit. Yes, you will learn what MI is. You will learn some of the most important pieces of MI, like spirit and method of MI, how they function, how it's different. However, please don't expect to know how to do MI, and don't advertise yourself now that you do know MI after this class. So MI is being a whole model to be able to do and particularly practice techniques, in my opinion, cannot be done in 3 hours in one lecture. So it's really, really important to set that expectations for students, what they are going to learn on that day and what the limitations of their learning are going to be. So I really like to frame that to students, because sometimes when they see MI, it's like, oh yes, and then after this day, I will know MI. You will know what MI is, not necessarily MI. So after that, I like to start with a little bit of historical relevance of MI. And I think Alan's story about blaming clients for repeated relapse is actually a great introduction of why MI is important, and actually to present and frame MI as a response in many ways to how mistreated clients were in the past and how much blame it was placed on them. So the MI really represented a dramatic shift in the approach of how we perceive clients, even the mere fact that clients should be believed when the things they tell you, that you should trust them, that this is their experience. Next, I also like to speak of the kind of theoretical positionality of motivational interviewing, because there's a lot of misconceptions and myths. And so really communicating to client that MI is not a theory, it's a trans-theoretical model. The authors themselves are very, very adamant. So I communicate to my students, please don't embarrass me and tell people that MI is your theory. It is not, because it's not a theory. So understanding how MI is positioned and then how it can be integrated within all their own theoretical positionality and being able to be integrated in practice. I also like to talk to students a little bit about potential discomfort that I may experience when practicing MI, because MI, as I mentioned, represents a pretty dramatic shift of how we approach addiction. And in my opinion, is the most dramatic shift away from the moral model. So really challenges any remnants of students embracing that model. So it might be a little bit difficult to, focus solely on, for example, change talk. Students would really want to focus on their problem. It really want to go onto that sustained talk side. So it's really important then to challenge and talk to students about some of the discomfort that I experience truly practicing MI, embracing it, conceptualizing clients from this perspective. Also like to focus a little bit on skill and clinical implications. So there's, to be able to communicate to students a lot of things that they already know are a functional part of MI, just intentionality of use might be a little different. So covering basic skills, so ORs, open-ended questions, affirmation, reflections, and summaries as a foundational part of MI, which students should know from their basic skills class, and then introducing some of the more advanced skills and how they can be used as a part of practice to be intentional in facilitating the change talk. Also covering, in our book, we cover stages of change model as an independent model that can be used in conjunction with MI, and particularly in terms of being able to assess where the client is and then tailor your intervention based on which stage of change client is. So essentially appropriateness of intervention regarding the stage of change that a client is in. And also like to focusing on understanding and honoring MI spirit. There's a lot of myths about MI being kind of a set of techniques that you can just use to get client or people in general to do what you want them to do. And Miller and Rolnick were really explicit in covering this in their last edition, that MI can only be used, and it's only MI if it's used with explicit focus of for the well-being of the client. So the spirit and the notion of what MI is for, it has to be honored. So really focusing on that piece and understanding the role of MI and emphasizing the autonomy of the client being the decision-making person, not necessarily to use these techniques to trick client to do what you believe is best for them, but rather help them achieve what they believe it's best for them. And then finally, I already chatted a little bit about that, about implications of change talk and the importance of recognizing the change talk. So using a lot of activities to be able to recognize change talk and then being intentional in using the skills to facilitate and strengthen the change talk when they recognize it.
Mm-hmm. And Ned mentioned 1 3-hour class. I actually can't teach MI just in one class anymore. I do 2 3-hour classes, one where we learn it and then the next one where we practice it. So yeah, but then I encourage them to go get additional training too.
Okay, just very briefly, because we want to leave time for some of the questions that some of you have posed to us. But some of the things that we include in the book, I mentioned case examples naturally. One of the things we really enjoy doing is, it's called Notes from the Field. These are interviews with addiction professionals who are working throughout the United States in various capacities. Some folks are working in prevention, others in treatment, and doing direct counseling of various sorts. Some folks working in medication-assisted treatment. So it really gives some interesting perspectives, and we've wanted to make this very timely. Same thing with boxed items. These are just little tidbits, usually based upon some recent research, and then learning activities. These are small group exercises that you can use with your class, helps to generate discussion, etc. So.
Great.
Great. Thank you, guys. Once again, we want to thank our presenters today, and the book that they've been referring to throughout the presentation is their brand new textbook, Addiction Counseling, A Practical Approach. We've got our 3 authors who are presenting today. Again, my name is Rhonda Dearborn. I am the editor here at Springer who worked with this great crew to create our new textbook, Addiction Counseling, A Practical Approach. We're going to go into Q&A now briefly, but I just want to review what you see here on the screen. If you're interested in adopting this textbook for your course, please reach out to our sales manager, Jill Legg. Her contact information is here on the screen. If you're interested in this book from a standpoint of bulk sales, continuing education, professional use of this book, if you need it for a meeting or a society or conference, Lee Montville, our Director of Special Sales, is the person to contact, and his contact information is here on the screen. If you want to purchase this book for your own use, you can take advantage of a 25% off free shipping discount code that you see here on the screen. So with that, I'm going to start posing some questions from folks who were in the chat today. What studies are out there that focus on relapse patterns and mental health disorders? Are there also then counseling approaches that specifically address this relationship?
I don't want to jump in if this wasn't my chapter to write. So I know my co-authors have more information about the co-occurring disorders, but from the relapse prevention side, we definitely do account for mental health concerns. And there are quite a few relapse prevention models. We cover 3 different models in the book, the mindfulness-based and some of the traditional ones that you would be aware of, but all of them look at triggers or warning signs for relapse and how that chain analysis is part of our work. And a lot of that has to do with when I feel depressed, that's when I have a warning sign or a trigger for using a substance or engaging in addictive behavior. And so it's integrated throughout the relapse prevention models that we use. I don't know if, Ned, do you have anything else from the co-occurring disorder side?
I'm sorry, I must have lost Rhonda. I didn't hear that part of the question. So Rhonda, do you mind speaking excuse me, about the co-occurring disorder question again?
Oh, no, the question was about what studies are out there that focus on relapse patterns and mental health disorders.
I mean, there is a lot of present. I can't think of a particular study I can point you to as far as the co-occurring issues, but more a general literature speaks of if there's a presence of co-occurring disorder, if one of the disorders not diagnosed and not treated increases risk of relapse exponentially. So it's more looking into the general pattern. Also, SAMHSA has a lot of resources. It has a whole workbook on co-occurring disorder that looks into specific implications. So I would definitely encourage you to visit, and we cover that in our book as a resource. The SAMHSA resource on co-occurring disorder, it's about 250 page handout essentially for clinical practice that reviews specific implications to relapse regarding disorders.
Yep.
Thank
and
you.
along with the co-occurring disorders, we also talk about in the book, and I think it's important to look at co-addictions. So if you're addressing one addiction and they're in recovery from that addiction, they're also at higher risk for another addiction to emerge. And we see that sometimes with chemical addiction and behavioral addiction. So I'm in recovery from alcohol use, but now I've started gambling, or I've started in acting out sexually and that kind of thing. So I think being aware of how relapse is predicted by both untreated co-occurring disorders as well as cross addictions or additional addictions.
Thank you. I've got one more question for you. I know earlier on in the presentation, you talked about a little bit about advocacy. What about policy change and advocating for policy change, specifically with regard to targeting practices that target specific minoritized populations with ads about gambling and alcohol, et cetera?
I'm so excited you asked this. So we actually have a chapter on advocating for addicted populations in the book. So we weren't able to include information about that in this webinar just because of time, but there are lots of opportunities for our students to get involved in advocacy efforts that are ongoing. So I kind of provide a history of advocacy in the addictions world, and that includes both chemical and behavioral. But we see Faces and Voices of Recovery is a big advocacy movement. And so after discussing kind of what's already been done and some of those legislative actions that have taken place so that people can get reimbursed for addictions treatment, we talk about what's left to do and how folks can get involved in advocating for those with both chemical and behavioral addiction. So I love that part of class because I feel like by the end, my students are like, okay, we see this as a problem. This is a systemic issue. How can we advocate? And so everything from advocating against these unfair targeting practices or putting some more regulations on some of these behaviors. And there's lots of things that I think that chapter could start conversations with your students of what advocacy could actually look like.
One last question, because I know we're bumping up against our hour. Do you cover trauma in the book is one last question.
We do. And I think it's in, Ned, is that in your chapter? I can't remember where we cover trauma.
So absolutely. So it's covered in co-occurring disorders. So as one of the, obviously trauma being extremely high rates of co-occurrence with addiction issues. So it's most explicitly covered in the co-occurring disorders, and look into the high rates of co-occurrence and looking into some, for example, etiology and presentation of trauma and how that's substances show up as a natural way to cope with resources when there's other lacks. So as far as the most explicit place, you'll find in co-occurring disorders and regarding the risk rates, but also trauma is covered throughout other chapters and relevance as far as group counseling and being able to address the issues of trauma as well.
We also talk about trauma and assessing trauma in the assessment chapter. So talk about the ACEs, and we also include a trauma scale that could be used. So so it's also very helpful to looking at trauma.
And we mentioned Seeking Safety and Atrium and a couple other manualized interventions that address trauma and addiction concurrently. So you can see those resources as well.
Also,
Fabulous.
just bring up one point about advocacy issues. That's a great assignment to have in class. One of the assignment to be, for example, students to write a letter to a state representatives. If you have access to, for example, Capitol Hill, to be able to take students and sit in on some of the sessions, the deliberation and show support. So advocacy is a very, very nice assignment that you can have to actually get students into practice of advocating for issues that can be relatively easily accessed, even just as simply as sending a letter to a representative on an issue regarding substance use issues.
Thank you, everybody. We're getting lots of comments. Thanking you all for a brilliant presentation. And again, we want to thank all the participants today for spending some of their afternoon with us. We know how time is so valuable. And I want to thank our presenters and all of our internal folks who helped put this event together. Thanks so much and have a great rest of your afternoon.
Thank you.
Bye-bye.
Bye.